The quick and dirty med school. Today we'll be going through the mediastinum. So the mediastinum lies in the thoracic cavity, and it's bounded about from the neck down to the diaphragm. The lateral partitions are going to be the lungs. The median partition is the actual mediastinum itself, and then the entire cavity is lined with endothoracic fascia. The mediastinum is mobile, so it's elevated and depressed due to its connection to the diaphragm, and it's bordered by the thoracic outlet, which is like this area right here, the diaphragm, the sternum anteriorly, the vertebral column posteriorly, and inside of it is the pleural sac. It contains the thymus, heart, veins, vagus and phrenic nerves, along with the sympathetic trunks, along with the pretracheal, paratracheal, and deep cervical lymph nodes, along with the esophagus and the trachea. And due to a pneumothorax, it's going to be displaced to the opposite side of the collapsed lung. So the right lung is collapsed, it's going to be displaced into the left lung. So let's go through the anatomical planes. Superior mediastinum, it means that it's above the sternal angle, which is that it's right at the manubrium. It's bounded by the manubrium anteriorly and the longus colli, remember the intrinsic neck muscles, along with the vertebra posteriorly. And it contains the thymus, the large arteries, subclavian, vagus nerves, the trachea and the esophagus, along with the thoracic duct and the sympathetic trunks. The inferior mediastinum is below the sternal angle, and it's bounded by the sternal body and the The inferior mediastinum is made into three parts. The anterior, which contains it's from the sternal body to the pericardium, the middle, which is from the pericardium to the esophagus, and the posterior, which is the esophagus to the vertebra. And all of those contain like the thymus, pericardium, heart, phrenic nerves, the vagus, aortic vessels, along with the lymphatics. The posterior mediastinum is the most narrow, and that's the only one that communicates with the abdomen via the trachea and the esophagus. Mediastinitis is inflammation of the mediastinum, and the causes are the neck infections that spread down the danger zone, and penetrating wounds, along with esophageal perforation that can be caused by trauma, surgery, or gastric acid. So people who suffer from GERD, like long time GERD, the stomach acid can actually eat through the esophagus. So air can escape into the connective tissue spaces and ascend up the neck and lead to emphysema, and it's just like air pockets right in the subcutaneous tissue. And injury to the lungs and the pleura can cause air to escape. And here are the other, various danger spots. Here in the interior mediastinum, the danger is cancer, because they can spread. In the middle mediastinum, the concern is for aneurysm, usually aortic aneurysm, along with some like cyst formation, diaphragmatic hernia, and lymphadenopathy, which is it's just a disease of the lymphatics. And then the posterior mediastinum, esophageal disease, GERD, like I said, some cancers, and the neurogenic masses. So mediastinocoscopy is used to diagnose the biopsy and lung carcinoma along with the lymph nodes. The incision is usually made like right here at the suprasternal notch, and then the scope is threaded through Okay, so lungs cancer can spread into the mediastinal lymph nodes, and those can compress the left laryngeal nerve, remember, because the left laryngeal is the only one that goes into the thoracic cavity, and then that causes paralysis of the left vocal cord fold. So when somebody starts describing their symptoms as like hoarseness of voice that just like appeared suddenly and hasn't gone away for several months, then the suspicion is lung cancer. So the most common masses are neurogenic tumors found in the posterior mediastinal area, and sometimes a thymoma or a pheocytochroma can occur, and those are in the interior mediastinum. That's far more rare, but the anterior masses tend to be more malignant, and there's these different stages. So stage N1, they involve the ipsilateral hilar lymph nodes. So if we look at these pictures, 10, so it's up here. And then N2 is going to be the ipsilateral mediastinal lymph nodes. And of course, like the further the stages are, the more malignant the cancer is. And of course, M1 is going to be one of the most dangerous because it spreads into the supraclavicular and the scalene nodes, and from there it can drain into the thoracic duct and then go everywhere. So the thymus, it lies in the superior inner pleural area of the mediastinum. It's bounded by the manubrium and part of the sternum anteriorly. Behind it is the carotid and brachiocephalic veins. So particularly important because in a thymoma, you want to be very careful doing a thymectomy because the carotid and the brachiocephalic is so close to it, and these are very large vessels, and the carotid is particularly high powered or has high pressured blood in it, and because of the high pressure, like a nick can kill somebody very quickly. So the thymus is larger in babies, and it goes through involution after puberty. Thymus plays a role in the development of the immune system. That's why it's kind of suspected once you go through puberty. Your immune system does not have to, it's not like it doesn't work or is less effective, but there's less for it to quote-unquote learn. The immune system has now been matured, so it's a little bit more effective than cranking out new cells all the time, because that is quite an expensive process for the body. So eventually the thymus doesn't go away completely, but through involution, it eventually replaced by adipose tissue. So this is a child at 3 months. Look how gigantic this thymus is. And then after 10 years, it becomes more filled with adipose tissue, and it shrinks. And then after 17 years, it gets even smaller. So there are 2 lobes in it inside of a fibrous capsule, and there's going to be the septa, which are made of fibrous capsule as well, and they separate those into the lobules. The thymus is supplied by the interior thyroid, the internal and inferior thoracic, and the mediastinal vessels, and all of that drains into the left brachiocephalic vein. And it's innervated by a couple small branches of these nerves. Okay, so DiGeorge syndrome, if you recall from other lectures, is one of the diseases, syndromes, genetic abnormalities that results in aplasia of the thymus. So you remember this by this mnemonic, catch-22. So C for the cardiac abnormalities, A for the abnormal facies, their faces look a little strange, and thymic aplasia, cleft palate, and because of that, the hypocalcemia and the hypoparathyroidism. All that is because there are going to be problems with the thymic gland and the thyroid gland. So the consequences of this is going to be immunodeficiency. On the opposite end, thymomegaly can be caused by steroid, chemo, radiation burns, systemic stresses, cancer, and sometimes it's just idiopathic. The consequences of thymomegaly is lymphoid hyperplasia, and usually there's diffuse symmetric enlargement, and myasthenia gravis is also associated with thymomegaly. So here's thymomegaly in an adult. Remember, it's not supposed to be this big at all. Okay, thymoma, it usually occurs in patients with myasthenia gravis, and removing the thymus completely sometimes make the symptoms just go away. The problem with thymomas is that they erode the nearby structures, and that causes vocal changes, coughs, shortness of breath. So it can be confused with bronchitis. So important to read these MRIs and X-rays very carefully. And the problems with the cough and the vocal changes is it compresses the laryngeal nerve, well, the recurrent laryngeal nerve, and all the thymomas are potentially cancerous. Okay, here we go. Thymectomy. It's pretty well vascularized. So here's the pericardium, here's the diaphragm, there's the mammary vessels, and then behind the thymus, remember, there's going to be the carotid. So a thymectomy is also used to access the heart and greater vessel in the neonatal period. So usually they cut through the mediastinum to access the heart and great vessel in neonates. So that's usually an open chest surgery. But in adults and teenagers, they go through a minimally invasive route, and they go through the neck or the subxiphoid instead. And sometimes you go and have a thoracic sympathectomy done to relieve flushing, hyperhidrosis, which is excessive sweating, Raynaud's disease or shoulder hand syndrome. That's a vascular problem where people can't tolerate heat or cold very well, and they have very painful, like tingling sensation in the hands. Okay, so pleura is a serous membrane, covers the lungs, and there are two components, the visceral and the parietal layer, and it's separated by the pleural cavity, and they're only continuous with each other at the hilum, or the root of the lungs, and the hilum, eventually goes into the pulmonary ligament. And the cervical pleura can go into the posterior triangle of the neck, and that's going to be covered by the suprapleural membrane, usually above, like an inch above the clavicle. And the costal pleura lines the inner thoracic wall between the ribs, except for in front of the vertebra, so it's more like just lateral. And then there's going to be the diaphragmatic and the mediastinal pleura. So mediastinal pleura is going to be the one that touches the heart. And all of the pleura really serve to help reduce the amount of friction when you breathe. Okay, recesses. There are the costodiaphragmatic in the inferior margin, and it's usually deeper in the back, of course, because the lungs are on like a hollow, like dome shape. So the mediastinal recesses in the anterior margin is going to be more shallow, and the recesses just allow air in with minimum friction during the expansion of the lungs. So it's kind of like a little pocket for, I don't want to say extra air, but it's there just in case you need to hyperinflate your lungs, like when you take a deep breath before jumping into the pool. So the parietal pleura is part of the thoracic wall, and it's going to be supplied by the anterior and posterior intercostal vessels, along with the superior phrenic and mediastinal arteries. And then the visceral part is going to be part of the lungs, so it's going to be supplied by the bronchial vessels. The parietal lymph will go into the peristernal and the internal intercostal lymph nodes, and then usually that drains into the inferior vena cava. And then the visceral pleura, The visceral pleura have a lot of lymphatics, and those penetrate deeply into the parenchyma, to the bronchial lymph nodes, and the tracheal lymph nodes. The parietal pleura are the ones that are sensitive to pain, touch, temperature, and pressure, because remember, it's a part of the thoracic wall. And it's innervated by the intercostal nerve along with the phrenic nerve. And then the visceral is only sensitive to stretch, so you only know how far or how deep of a breath you've taken. And it only receives an autonomic nerve supply from the pulmonary plexus. Alright, so inside the parietal cavity should, or the pleural cavity, I'm sorry, it should only be about like 5 to 10 milliliters of fluid, and it's made from hydrostatic and osmotic pressure, is used to reduce the fluid, or friction, and it's secreted by the capillaries of the parietal pleura, and it's absorbed into the visceral pleura. We start getting concerned of a pleural effusion if the fluid exceeds 300 milliliters. And when you listen to a patient with a lot of pleural fluid or a pleural effusion, they're going to have decreased breath sounds, and it's going to sound scratchy, like you're crunching up like cellophane or newspapers. And when you tap the lungs, it's going to sound dull, so it's not going to sound hollow. I do really recommend rapping on random objects. It sounds very strange, but it's really important to know what a dull percussion and a hollow percussion sound like. Or in the hospital, we use the term tympanic. So it's really, really important to know this. And empyema is going to be pus in the pleural cavity, and it's going to sound like pleural fluid, but even more pronounced. So the breath sounds would be very decreased, and then the percussion would be like hitting like a solid object, nothing tympanic. Pleurisy is the inflammation of the pleura, and it's a complication of pneumonia, most common, or sometimes an injury to the thoracic wall. The pleural surfaces are usually coated with an inflammatory exudate, and that causes the surfaces to roughen. And then friction and pleural rub occurs. And because there's going to be that friction, it's going to be very painful whenever the patient takes a breath. And then the exudate is going to be invaded by the fibroblasts, which lay down collagen and bind the pleura together. So the consequences of this is that it's going to be very painful for the patient to take any deep breaths, so they're going to breathe like quickly and shallowly, and they're not going to be able to expand because the elasticity of the lungs has now decreased due to the invasion of collagen, which is, as you know, not very stretchy. And unfortunately, this is permanent. So what you can only do is to put the patient on oxygen and maybe some kind of bronchodilator to relax the lung a little. Okay, pneumothorax. Back in the day, and by back in the day I mean like last century, it was artificially done as an old treatment for tuberculosis, so it can rest the lung. But nowadays it's really like a spontaneous pneumothorax. It usually happens in males who are very tall and very slim. Patients who are they suffer from Marfan's or Ehlers-Danlos will also have spontaneous pneumothorax. And there's a couple different types. Open, usually that's because of a trauma, usually like a stab wound or something very sharp has penetrated the lungs. And air will come in and out of the body. And in closed pneumothorax, it's also known as a tension pneumothorax, air will enter, but it can't leave, so there's going to be increased pressure, and there's going to be displacement of the mediastinum, a pretty significant displacement as well. And as you can see here, here's the collapsed lung, and there's several different types. Hydropneumothorax, where water is in the lungs. Hemopneumothorax, that's blood. Pneumothorax, that's pus. This is pretty serious. I mean, all of them are pretty serious, but this is usually a tiny bit more serious because you're now concerned about sepsis. Hemothorax, that's going to be blood in the thorax itself, and chylothorax, which is very rare. It means that there's going to be lymph in the thorax. And fluid will pool in the costal diaphragmatic recesses. See, this is a better picture. Look at all that fluid. Okay, so what happens if you have all that fluid? You perform a thoracentesis, and it's an evacuation of blood or fluid, air, and pus. And for fluid effusion, you tap between the 7th and 8th intercostal space. Remember that you have to insert the needle or at a 45-degree angle right above the superior aspect of the rib, so right above the 8th rib. And this is to avoid damaging the intercostal nerves. And then for an air effusion, you tap between the 2nd and the 3rd intercostal space. Usually like anteriorly. You do a thoracostomy when the tube is inserted at in the 4th, 5th intercostal space along the anterior axillary line. So, patient raises their arm, you find the axillary line, and the tube is inserted. And that's usually only when large amount of fluids have to be removed. And then it's all put in a special container with an antiseptic solution that allows the air to leave without introducing anything new into the opening. Okay, that's it for now. Thank you for your attention and good luck studying.